All right. Let's jump right into something super important for anyone working with cancer and transplant patients. Accurately diagnosing latent TB infection.
Absolutely.
We all know these patients are already so vulnerable to infections. And TB is a big one.
Yeah, it really is. Accurately identifying latent TB in these immunocompromised patients is a huge challenge.
It is.
And the stakes are high if we miss it.
Exactly. And that's what makes this recent study so interesting.
Yeah.
It was just published last month in Transplant Infectious Disease.
Oh, wow.
And the researchers over at MD Anderson Cancer Center really dove deep into comparing how well those two interferon-gamma release assays perform.
The IGRAs?
The IGRAs.
Right.
T-SPOT.TB and QuantiFERON-TB Gold, or QFT-TB for short.
I think everyone's familiar with those two.
Yeah, they've become kind of the go-to for screening for latent TB.
Especially with all the limitations of the good old tuberculin skin test.
Yeah, especially in this population.
Right.
So what makes this study so important?
I think it really boils down to,
This question: can we confidently say that one of these IGRAs is really more reliable and accurate than the other when it comes to these incredibly vulnerable patients?
And is there one that we can kind of feel good about and say, okay, this one's the best one to use?
Right. And I think the authors really wanted to kind of get to the bottom of that.
Yeah.
And they found some really interesting results.
Yeah, they did.
That I think have some pretty significant implications for how we approach screening and treatment for latent TB in our patients.
Absolutely. So before we get into the nitty-gritty of the study, let's just take a step back and kind of set the stage a little bit.
Sounds good.
We know that latent TB infection is a global health issue.
It is a big one.
Yeah, it's a huge one. Estimated that billions of people are affected worldwide.
Yeah.
But why should we be particularly worried about this in cancer and transplant patients?
Well, because for these patients, it's not just about having that latent infection.
Right.
It's about that risk of it progressing to active TB disease.
Right. Yeah. Their immune systems are just so weakened that they are far more susceptible to reactivation.
And it's not just a slight increase in risk, is it?
No, not at all. Studies have shown progression rates as high as 20%.
Wow.
In some immunocompromised populations.
That's a big number.
Yeah, we can't ignore that.
We can't ignore that. So does the type of cancer a patient has influence their risk of progression?
It does, yeah. The research consistently shows that patients with hematologic malignancies, like leukemia and lymphoma, they face an even higher risk of progressing to active TB than those with solid tumors.
Makes sense given the impact those malignancies have on the immune system.
Right.
And then, of course, we can't forget about our hematopoietic stem cell transplant recipients.
Absolutely incredibly vulnerable in that post-transplant period.
Right.
And the guidelines recommend testing for latent TB before they even undergo the transplant.
Before they even go through the transplant.
Yeah.
So with all of that in mind, the need for a really good test to identify latent TB in these patients is absolutely critical.
It is.
And that's where our IGRAs come in.
Exactly.
T-SPOT.TB and QFT-TB.
They really have become essential tools
Yeah.
for protecting these vulnerable patients.
Absolutely. So let's get into the nuts and bolts of this study. How did the researchers actually go about gathering their data?
So they did a retrospective study looking back at data from MD Anderson Cancer Center over a 7-year period from June 2010 to July 2017.
Okay, a pretty significant time frame.
Yeah.
What patient population were they looking at?
So they included a total of 12,299 patients in their analysis.
All right.
A mix of cancer patients and hematopoietic stem cell transplant recipients. All of whom had undergone either T-SPOT or QFT-TB testing during that 7-year period.
Got it. So they had a good sample size to work with.
Yeah.
How did they go about actually collecting all this data?
They did a thorough chart review for each patient, and they were extracting information on demographics, cancer type, HIV status, the results of their IGRA test, whether it was positive, negative, indeterminate, or invalid, and a whole bunch of other relevant lab data. Okay,
so really digging deep into the medical records to get a comprehensive picture of these patients and their IGRA results. And this is where it gets really interesting.
Yeah.
Let's move on to the results and see what they found.
Let's dive in. So when they looked at the two IGRAs head-to-head, one of the biggest differences they found was in the rate of actionable results.
Actionable meaning it gave you a clear positive or negative result to work with.
Exactly, gives us a clear answer so we can make decisions about treatment.
Okay.
And in this area, T-SPOT.TB really stood out.
Wow.
It had a much higher rate
Okay.
of producing those clear results, whether positive or negative, compared to QFT-TB.
How big of a difference are we talking here?
We're talking 89% for T-SPOT.TB versus just 65% for QFT-TB.
So that's a 24% difference in actionable results.
That's huge.
That is a big difference, especially with these patients who are already at such a high risk of progressing to active TB.
Right. Any delay in diagnosis and treatment could have serious consequences.
For sure. So what about the opposite of that? The rate of indeterminate or invalid results.
Right. The ones that don't give us a clear answer.
The ones that leave you kind of scratching your head like, what do we do now?
Exactly. And that's another place where the two tests were really different. QFT-TB had a way higher rate of indeterminate results, 35%, while T-SPOT.TB had only a 10% rate of invalid results.
So more than 3 times.
Within 3 times.
The rate of inconclusive results with QFT. Did the study shed any light on what might be behind those indeterminate or invalid results?
They did.
Okay.
They did find some interesting associations.
Okay, like patient characteristics?
Yeah. So for T-SPOT.TB, they found that prior use of alemtuzumab.
Oh, umtuzumab.
Yeah.
That monoclonal antibody we use in stem cell transplant.
Exactly.
Okay.
They found that was linked to invalid results. Also, lower hemoglobin levels, a low absolute lymphocyte count, and low serum albumin were all associated with those invalid T-SPOT results.
So factors that really reflect the level of immunosuppression in these patients.
Exactly.
Okay. What about for QFT?
Yeah, so for QFT, they found some different factors.
Okay.
Female gender was a predictor
interesting.
of indeterminate results.
Okay.
Along with use of systemic corticosteroids.
Corticosteroids, another common treatment in our cancer patients.
Right.
Something to keep in mind when we're looking at these test results.
Absolutely.
Okay.
And just like with TCSPOT, lower hemoglobin, and serum albumin were also linked to indeterminate QFT-TB results.
Okay.
But interestingly, they also found an association with a higher absolute neutrophil count.
So maybe a sign of inflammation or infection playing a role there.
Yeah, potentially.
It just shows how complex these patients are.
It really does.
So many factors to consider.
Yeah. And that's why having a test that can give us a clear answer as often as possible is so valuable.
Absolutely. So we've talked about rates of actionable results and indeterminate results.
Yeah.
Did they look at how the two tests performed when they were both used in the same patients?
They did.
Okay.
And this is another important finding.
Okay.
They found that when both tests were used in the same patient, there was actually poor agreement between the two.
Really? So even in the same patient, the two tests didn't necessarily match up.
Right.
Which makes you wonder which one's really giving you the true picture.
Exactly. It really raises questions about reliability.
Yeah, for sure. So let's talk about what all this means for us clinically.
Yeah.
What are the big takeaways here for those of us working with cancer and transplant patients?
I think one of the biggest takeaways is that T-SPOT.TB consistently had that higher rate of actionable results.
Right.
It also identified more cases of latent TB infection compared to QFT-TB.
So leading to potentially faster diagnosis and treatment.
Exactly.
Which is huge for these patients.
Absolutely.
So would you say then that T-SPOT might be the better option for screening these patients?
I think based on these findings, there's a strong argument for that.
Okay.
It seems like it gives us a clearer picture of the patient's TB status more consistently, and that can really help us make those treatment decisions with more confidence.
Right, and feel better about those decisions.
Yeah.
Of course, we always have to consider the real-world factors, too.
Absolutely. Cost, availability, individual patient characteristics.
Right. It's never a one-size-fits-all situation.
It's not.
But this definitely gives us a lot to think about.
It does.
Now, I know no study is perfect. Were there any limitations to this one that we should be aware of?
Yeah, there were a few limitations.
Okay.
First of all, it was a retrospective study.
Right. So we're limited by what was in the medical record.
Exactly. And they mentioned that some data points, like CD4 counts and TST results, were missing for some patients.
Which would be interesting to have to see if that would have changed anything.
Yeah.
And also, the tests were often done at different times for the same patient.
Yeah. So it's hard to compare directly.
Right, because there are always those real-world variables.
There are.
Okay.
But even with those limitations, I think this study gives us some valuable insights.
Absolutely.
That can help us improve how we approach TB testing in these patients.
So sure. Okay, so we've talked a lot about this study and what it found.
Yeah.
Now, I want to ask you and our listeners out there a question.
Okay.
Given the higher rate of actionable results and potentially better accuracy with TSPO-TD,
right,
how do we as a community deal with the cost issue? Because QFT has generally been the cheaper option.
Yeah, that's a great question.
Yeah.
And one we have to think about. You're right, cost is a major factor. But I think we have to ask ourselves, what's the cost of a misdiagnosis or a delayed diagnosis?
Right.
Could using TSPO-TB, even if it costs a bit more, actually lead to better treatment and better outcomes for these patients in the long run?
That's the real question, isn't it?
Yeah.
Balancing cost with benefit.
Exactly.
It's tough.
It is a complex issue.
It is.
And it's something we need to be talking about.
Absolutely.
Not just clinicians, but researchers, policymakers, and even the patients themselves.
I think this is a good place to pause for now.
Okay.
We've covered a lot.
And we have.
I'm sure our listeners have a lot to think about. So where do we go from here? What are the next steps?
Well, I think we need more research.
Yeah.
This study really brought up some important questions, and we need more studies to really get some solid answers and guidance for how we practice.
So what kind of research specifically?
Well, for one, we need more head-to-head comparisons of TSPOT and QFT, specifically in these patients.
Yeah.
You know, a prospective study where we're directly comparing how they perform in the same individuals would give us much stronger evidence.
The head-to-head trial would be really helpful.
It would.
What other research should we be looking at?
I think we need to dive deeper into the cost-effectiveness of using TSPOT as our main screening tool.
Right, because cost is always a factor.
Always.
And we need that data to make good decisions about how we use our resources.
Exactly. We need data to tell us if that extra cost is worth it.
Right. Is it balanced out by that better accuracy and earlier treatment?
Exactly.
Makes sense.
And I think it's also really important to figure out what's causing those indeterminate and invalid results.
Yeah.
If we understand that better, maybe we can come up with ways to reduce those inconclusive findings.
And get more accurate results overall.
Yeah, exactly.
It's tough when you get that indeterminate result.
It is.
It leaves everyone hanging.
Yeah, it creates a lot of uncertainty.
So research is key.
Yes.
But what else?
Education.
Okay.
We need to make sure clinicians who are taking care of these patients are up to speed on all the ins and outs of these IGRA tests.
That makes sense because even experienced clinicians might not know everything about how these tests work.
Exactly. And there's always new research coming out, new information about these tests and how they compare and how that affects how we manage patients.
So education is always key.
Always.
And I think we need to keep advocating for policies that ensure everyone has access to these tests.
Absolutely.
Regardless of their income or insurance.
Couldn't agree more. Cost and access shouldn't be barriers for these patients.
Well said. Okay, so we've reached the end of our deep dive on this important topic.
Yeah, this has been a great discussion.
We've looked at the study, gone over the findings, and talked about what's next.
Yeah.
Hopefully this has given our listeners some things to think about.
Absolutely.
And some practical tips for their practice.
Yeah, and I just want to add, it's so important for everyone in our field to stay curious, to stay up to date, and to keep looking for better ways to protect our patients.
Absolutely, because knowledge is power.
It is.
Especially when we're caring for these vulnerable patients.
Well, for sure.
So until next time, keep learning and keep striving to make a difference for your patients.